Kanski lecture series, and this is we are going to start today the chapter 3 lacrimal drainage system, and it's going to be the part 1. So let's get started. So in this part we are basically going to discuss when the tears are formed, how they are drained and they get out of the eye. So basically the lacrimal drainage system is present on the medial side of the eye. So let's get started with the anatomy. So the lacrimal drainage system consists of the following structure: the puncta, the canaliculi, the lacrimal sac, and the nasolacrimal duct. So puncta are located at the posterior edge of the lid margin at the junction of the lash pinning lateral fifth sixth pars ciliaris and the medial non-ciliated 1/6 pars lacrimus malis. Normally, they face slightly posteriorly and can be inspected by everting the medial aspect of the lid. Treatment of watering caused by punctal stenosis or malposition is relatively straightforward. So basically, puncta is basically the opening which is present in the uh, eyelid margin, and these are at the lateral fifth, sixth, and 1/6 of the eyelid. And basically, when you evert the eyelid, you can see a very small hole in the eye, and that is the puncta. Next is the canaliculi. Canaliculi passes vertically from the lid margin for about 2 mm ampullae. They then turn medially and run horizontally for about 8 mm to reach the lacrimal sac. The superior and the inferior canaliculi, usually 90%, unite to form the common canaliculus, which open into the lateral wall of the lacrimal sac. Uncommonly, each canaliculus opens separately into the sac. A small flap of mucosa, Rosenmuller valve, overhangs the junction of the common canaliculus and the lacrimal sac, the internal punctum, and prevents the reflex of the tear into the canaliculi. Treatment of canalicular obstruction may be complex. So this is a picture. Basically, it is showing us that there is a puncta, and then there is a starting of the canaliculi. So canaliculi is first, there is a vertical which is about 2 mm and the horizontal which is about 8 mm, and total it forms the 10 mm of it. So first 2 mm is called the ampulla, and the second is called the canaliculi. Basically, most of the time the upper and the lower canaliculi join to form a common canaliculus, and then it open into the lateral wall of the lacrimal sac, and it is guarded by the valve of Rosenmuller. So next is the lacrimal sac. Lacrimal sac is 10 to 12 mm long and lies in the lacrimal fossa between the anterior and the posterior lacrimal crust. The lacrimal bone and the frontal process of the maxilla separates the lacrimal sac from the middle meatus of the nasal cavity. In the Dacryocystorhinostomy, and anastomosis is created between the nasal sac and the nasal mucosa to bypass an obstruction in the nasolacrimal duct. So next is the lacrimal sac, which is about 10 to 12 mm, most probably 10 mm. It lies between the interior and the posterior lacrimal crust, and it lies against the nasal mucosa. Next is a nasolacrimal duct. Nasolacrimal duct is 12 to 18 mm long, and it is the inferior continuation of the lacrimal sac. It descends an angle slightly laterally and posteriorly to open into the inferior nasal meatus. So very important, it opens into the inferior nasal meatus. Lateral to and below the inferior terminate, the opening of the duct is partially covered by the mucosal fold valve of Hassner. So you can see that here is a lacrimal duct, and it is guarded by the valve of Hassner. So what is the physiology of that lacrimal drainage system? How tears are being secreted, drained? So basically, the tears are secreted by the main and the accessory lacrimal gland, which is the glands of Wolfram and Cross, pass across the ocular surface. A variable amount of the aqueous component of the tear film is lost by evaporation, and the remainder of the tears hypothesized to drain substantially as follow. So blinking has a very important role in basically in making the tear drain, and also it also keep all the eye covered with the tear film, spread of the tear film. Tear flow along the upper and the lower marginal strip, pulling in the lacrimalis medial to the lower puncta, then entering the upper and lower canaliculi by combination of the capillary and suction. With each blink, the pretarsal and the orbicularis oculi muscle compresses the ampullae, shortens and compresses the horizontal canaliculi, closes and moves the puncta medially, resisting reflux. Simultaneously, contraction of the lacrimal part of the orbicularis oculi creates a positive pressure that forces the tear down the nasolacrimal duct and into the nose, mediated by the helically arranged connective tissue fiber around the uh, lacrimal sac. When the eye opens, the canaliculi sac expand, creating a negative pressure that draws the tear from the canaliculi into the sac. So in this portion, you have to understand about the positive and the negative pressure. So usually the lacrimal sac have a negative pressure when you are opening the eyes. So what happen is, when the tears are pooling in the upper and lower eyelid margin, and basically pooling in the lacus lacrimalis, then the tears flow to that lacrimal gland because of the negative pressure. You know that the water flow from positive to negative. So when the eyes are open, there are negative pressure in the lacrimal gland, lacrimal sac, sorry. So what happened is that the tears move from by the capillary action from the canaliculi into the lacrimal sac. So whenever patient blink, it will cause the shortening of the ampulla, and it will cause the closing of the puncta, and it will prevent that the tears in the lacrimal sac then go back. Rather, it causes the positive pressure, and because of the positive pressure, it the tears from the nasolacrimal duct into the nose. So these are how the tears are trained. And you can see figure 3.2, physiology of the lacrimal drainage system. A tear flows along the marginal strip, pulling into the lacus lacrimalis. Contraction of the orbicularis oculi muscle with each blink forces tears down the nasal lacrimal duct. When the eyes open, the canaliculi sac and the expand, creating a negative pressure that draws the tear from the canaliculus into the sac. Next is the causing of the watering. So basically, the watering eyes is having because of a hypersecretion, and another is a defective drainage. So hypersecretion can occur due to some inflammation, or can be due to dry eyes. So epiphora is the overflow of the tear at the eyelid margin. There are two mechanisms: hypersecretion and defective drainage. Hypersecretion secondary to the interior segment disease, such as dry eye, paradoxical watering, or inflammation. In these cases, watering is associated with symptoms of the underlying cause, and the treatment is usually medical. It is common for the watering eyes to be caused by the reflex hypersecretion of the tear secondary to the dry ocular surface. Defective drainage due to a compromised lacrimal drainage system. This may be caused by malposition of the lacrimal punctum, obstruction at any point along the drainage system from the punctal region to the valve of Hassner, lacrimal pump failure, which may occur secondarily to the lower lid laxity or the weakness of the orbicularis muscle. So basically, the hypersecretion, the defective drainage, can be either due to because of the lacrimal puncta is stenosed or is malposition. It can be due to obstruction at any point. It can be due to the lacrimal pump failure. Basically, it occurs in the 7th cranial palsy when there is a weakness of the orbicularis muscle. Evaluation history inquiry should be made about the ocular discomfort and redness to aid in excluding hypersecretion. Drainage failure tends to be exacerbated by a cold and windy environment, and to be least evident in a warm, dry room. A complaint of the tear overflowing onto the cheek is likely to indicate drainage failure rather than a hypersecretion. So basically, you have to take the history of the patient, so to know that if the lesion is due to hypersecretion or due to the drainage defect. Next is that you evaluates. First of all is an external examination. Punctal abnormality is the most common cause of the lacrimal drainage failure. The puncta and eyelid should be examined using a slit, and it is critical that examination of the puncta is performed prior to the cannulation for the diagnostic irrigation, which temporarily dilates the punctal opening and masks stenosis. So you have to basically see the puncture, that if it is stenosed or having a obstruction, there will be often be obvious tear flow from the medial or less commonly the lateral canthal region. Visible mucopurulent discharge is more likely to occur with a nasolacrimal duct obstruction than a blockage more proximally. So whenever you see a mucopurulent discharge in a patient with the epiphora, it is most likely that it is the obstruction is slightly posteriorly, maybe in the lacrimal sac, than interiorly. Punctal stenosis, this is extremely common and it has been reported as present in up to half of the general population. Over half the patient with evident stenosis are asymptomatic, in many cases due to insufficiency of the tear production or increased evaporation. So sometimes the punctal stenosis is not very common, evident. Why? Because the patient is either suffering from dry eye or having an increased evaporation due to blepharitis or any other condition. Ectropion, either localized due to the punctal region or involving the wilder lid, is often associated with secondary stenosis. Punctal obstruction, usually partial or by the fold of the conjunctiva. Conjunctivochalasis is common but underdiagnosed. So basically, the conjunctivochalasis is a condition where there is a loose redundant conjunctiva that is basically obstructing the puncta, and it is causing the punctal obstruction. Occasionally, an eyelash may lodge into the ampulla. A large crunkle may displace the puncta away from the globe. In the presence of the substantial lid laxity, the puncta may rarely override each other. A pouting puncta is a typical of a canaliculitis. Very common. It is very common as an MCQ's point of view. If a puncta is pouting, it means that it is having a canaliculitis. The eyelid skin will often moderately scaly and erythematous in a chronic epiphora. Centurion syndrome is characterized by the interior malposition of the medial part of the lid with displacement of puncta out of the lacus lacrimus due to the prominent nasal bridge. So basically, in case of Centurion syndrome, because of the prominent nasal bridge, there will be the interior malposition of the medial part of the lid, and which causes the puncta out of the lacus lacrimus. In a small child, the commonest cause is punctal stenosis. Occasionally, congenital glaucoma can present in this fashion. A child with a congenital glaucoma can present with watering eyes. It present with watering eyes, blepharospasm, and photophobia. A lacrimal sac should be palpated. Punctal reflex of a mucopleural material on compression is indicative of a mucocele, a dilated mucus-filled sac. Here spelling mucocele with a patent canalicular system, but with an obstruction either at or distal to the lower end of the lacrimal sac. In addition, in acute aqueous cystitis, palpation is painful and should be avoided. Rarely, the palpation of the sac will reveal a stone or tumor. So basically, the writer is trying to say, for example, this is a lacrimal drainage system, and sorry, I will make it again. So this is a lacrimal drainage system. This is upper canaliculus, lower canaliculus, and they both join, and there is a sac, and then it go down. So what happened is, basically, when the obstruction is here, for example, in a nasolacrimal duct blockage, when you press, there will be the retention of the secretion here. So when you press this sac, there will be the reflux, because it cannot go down, it will come back here. So it is showing that the reflux, the blockage is more distal. So nasolacrimal duct obstruction will cause the reflux of the mucopleural discharge. But if the obstruction is interior, then there will be the less chances that there will be the any kind of reflux. Next is a fluorescent disappearance test. So, fluorescent, the marginal tear strip of both eyes should be examined on the slit lamp prior to any manipulation of the eyelid or installation of a topical medication. Many patients with watering do not have an obvious overflow of tear but merely show a high meniscus marginal tear strip of 0.6 mm or more versus 0.2 to 0.4 mm normally. The fluorescent disappearance test is performed by instilling fluorescent 1 to 2% drop into both conjunctival furnaces. Normally, little or no dye remain after 5 to 10 minutes. Prolonged retention is indicative of an inadequate lacrimal drainage. This should be distinguished from the fluorescent clearance test used to assess the tear turnover in dry eye, in which the retained stain is measured in the meniscus 15 minutes after the installation of a 5 microliter of fluorescent. So another test is a fluorescent disappearance test. So sometimes that there is a that a tear film can be seen on the lower eyelid margin, and basically the meniscus is almost 0.2 to 4 mm normal, but when it is greater than 6 mm it indicates the higher meniscus. And what do you do in the disappearance test is that you put the 1 to 2% drop of the fluorescent in eye, and then you see the eye after 5 to 10 minutes. Basically after 5 to 10 minutes usually no dye remains. And there is another test, fluorescent clearance test, which is used to assess the dry eye. Basically in which you measure the retained state in the meniscus 15 minutes after the installation of the 5 microliter of fluorescent. Basically, we will discuss it in the dry eye chapter. But fluorescent disappearance test is that a fluorescent will not disappear in a case of the poor lacrimal drainage system. Next is a lacrimal irrigation. Lacrimal irrigation should be performed only after asserting punctal patency. If absent or severely stenoed, surgical enlargement of the punctum may be needed before canalicular and nasolacrimal duct patency can be confirmed. It is contraindicated in acute infection. So basically, you use the syringing to see, and you do the irrigation to see that where the obstruction or drainage problem is. So these are some picture. A is showing marked punctal stenosis. You can see that there is a punctal stenosis. B is showing the ectropion, mild medial ectropion. C is showing conjunctival chalasis. D is showing the hair follicle in the ampulla, and E is showing truncal large, and F is showing the pouting punctum in case of acute canalicular colitis. So this is showing the high marginal tear meniscus strip stained with fluorescent. And now we will discuss the lacrimal drainage system. Local anesthetic is instilled into the conjunctival sac. A punctum dilator is used to enlarge the punctum orifice, entering vertically, then tilting the instrument horizontally while exerting the lateral tension on the lid. Basically, we do it because of the anatomy, because the anatomy is like it is 2 mm vertical and then horizontal. So you first go straight and then you turn the instrument horizontally. A gently curved blunt tip 26 to or 27 gauge lacrimal canalio on a 3 ml saline filled syringe is inserted into the lower punctum, and whilst keeping a gentle stretch laterally on the eyelid, advanced a few millimeter following the contour of the canaliculus. A hard stop occurs if the cannula enter the lacrimal sac, coming to a stop at the medial wall of the sac, which can be left felt the rigid lacrimal bone. Thus exclude complete obstruction of the canalicular system. Gentle saline irrigation is then attempted. If saline passes into the nose and throat when it will be tasted by the patient, a patent lacrimal system is present, although there may still be stenosis. Alternatively, symptoms may be due to subtle lacrimal pump failure. Failure of the saline to reach the throat is indicative of a total obstruction of the nasolacrimal duct. In this situation, the lacrimal sac will be distended slightly during irrigation, and there will be the reflux, usually through both upper and lower punctum. The regurgitated material may be clear, mucoid, or mucoplurin depending on the content of the lacrimal sac. So basically this is what is it showing. So first of all, the punctum is getting dilated, and then after the dilation of the punctum, we take the cannula, we put it vertical, then horizontal, and there is a irrigation is performed. So what, first of all we have to see that if after going horizontally, is the feel of the syringe is having a hard stop or having a soft stop. If the feel is having a hard stop and the patient felt the patient felt the fluid into the, after syringing the patient felt the fluid into the nose, it means that uh, lacrimal drainage system is patent, and the tear overflow may be due to the subtle lacrimal pump failure or a mild stenosis. Whereas if there is no